Good morning. Today, our group will be presenting on healthcare disparities among sexual and gender diverse populations, a transcultural nursing perspective, presented by Lama Todmia, Kalia Sanders, Jennifer Okpalogu, Morgan Taylor, Kaylee Jacobs, and Eric Nunez.
The patients we are failing to see. Every day, patients enter healthcare settings hoping to feel safe, respected, and understood. But for many sexual and gender diverse patients, the healthcare setting itself can become another source of stress. In order to get a better understanding of this topic, I think it's important to define a few terms, such as sexual orientation, which is in reference to a person's emotional or sexual attraction to others. Gender identity is a person's more internal sense of being male, female, both, neither, or someone else along the gender spectrum. And then there's gender expression, which is how someone presents their gender through things like appearance, clothing, behavior, mannerisms. And then there's also sex assigned at birth, which refers to the biological sex assigned when someone is born based on only physical anatomy. And then finally, when we use the term LGBTQIA+, we're referring to a more broad community that includes lesbian, gay, bisexual, transgender, queer, or questioning individuals, along with many other sexual and gender minority groups. And one of the most important ideas to remember is that these communities are not just one uniform cultural group. Every patient has their own unique experience that are influenced by many different aspects of their identity. And this concept is known as intersectionality. And a person's healthcare experience is shaped not only by their sexual orientation or gender identity, but also other factors like age, race and ethnicity, socioeconomic status, and even where they live. And these factors can either improve or limit their access to healthcare, because there are others that may have more access to affirming healthcare providers and have a much more different experience than someone that lives in a more rural area with limited resources. And it's emphasized that these overlapping identities influence how people experience acceptance, discrimination, and those access to resources. It's also worth noting that LGBTQ+ individuals are also members of racial or ethnic minority groups that may also experience additional challenges because multiple identities intersect to shape different healthcare experiences. And it's also important to discuss the several barriers that the LGBTQI+ patients continue to encounter, such as misgendering, which occurs when a person is referred to using incorrect pronouns or gendered language. And another is dead naming, especially when a transgender individual is called by a name that they no longer identify with. And because of this, there's a lot of healthcare providers that may also unintentionally make heteronormative assumptions, such as assuming every patient has an opposite sex partner, or assuming someone's sexual health risks are based solely on their identity. These assumptions can then lead to incomplete sexual and reproductive health assessments, as well as preventative screenings and patient education that doesn't really meet the individual's healthcare needs. And patients continue to experience severe discrimination because of these instances that discourage them from seeking healthcare altogether. And limited education among healthcare providers can further contribute to that discomfort or that misinformation that occurs during the patient's encounters. At the system level, healthcare organizations may unintentionally create additional barriers, such as binary intake forms that force patients to choose whether or not they're male or female, even when those options don't accurately represent their identity. And electronic health records may also lack appropriate fields for documenting chosen names, pronouns, or gender identity, increasing that likelihood of repeated misgendering throughout their patient care. Because of these experiences, many of these patients report difficulty locating healthcare providers that are knowledgeable and are affirming. It's worth noting that many sexual and gender diverse individuals actively seek care at community centers dedicated to the LGBTQ+ community because they perceive those environments as more welcoming and affirming. And before healthcare organizations can improve culturally responsive care, they first need to understand where these knowledge gaps exist within their own staff. And one way to begin is through a needs assessment. Now imagine a nurse educator reviewing staff survey results before developing a cultural competency program. So some useful questions that might be included would be, how confident are you asking patients about their chosen name and pronouns? Can you explain the difference between sexual orientation and gender identity? Can you perform an anatomy-based health assessment without making assumptions? Or have you received formal education about LGBTQIA+ healthcare? Or do you know how to document a patient's chosen name, the pronouns, sexual orientation, and their gender identity appropriately? So a comprehensive needs assessment should also evaluate organizational practices, including patient complaints, any reports of misgendering or discrimination, any current staff education, intake forms, EHR documentation, and looking at both the individual knowledge and the organizational systems to help identify where improvements are needed most within these areas. The biggest takeaway, I think, is that cultural community begins by recognizing that healthcare professionals and healthcare systems may unintentionally create barriers for LGBTQI+ patients. By becoming aware of these barriers, reflecting on our own assumptions, and remaining committed to lifelong learning, nurses can provide care that is more respectful, inclusive, and, of course, patient-centered. So before we can improve these patient outcomes, we need a framework to help us examine our assumptions and develop practical skills and change the systems that cause harm. And before we can change patient outcomes, we must first need the right tools. And that begins with understanding more cultural competencies as an ongoing process.
5 skills, 3 actions, 1 goal. Now that we've identified why the training is needed, the next step is understanding the tools healthcare professionals can use to provide more culturally responsive care. The first framework we'll look at is the Campania-Bacot model of cultural competence. This model views cultural competence as an ongoing process made up of 5 interconnected components. That is cultural awareness, cultural knowledge, cultural skill, cultural encounters, and cultural desire. First is cultural awareness. Think of this as looking in a mirror. As healthcare professionals, we have to recognize our own beliefs, biases, and assumptions and how they may affect our interactions with patients. For example, instead of automatically asking a female patient, "Do you have a boyfriend?" we can simply ask, "Do you have a partner?" This prevents us from making assumptions about a patient's sexual orientation or relationships. Our paper emphasizes that recognizing these heteronormative assumptions is an important part of providing inclusive, patient centered care. Next is cultural knowledge. This means actively educating ourselves about populations that may have experiences different from our own. For sexual and gender diverse patients, this includes understanding appropriate terminology, health disparities, barriers to care, and the importance of inclusive communication. The third component is cultural skill. This is where we take what we've learned and actually apply it during patient care. Something as simple as asking a patient what name and pronouns they prefer can help create a safer and more respectful healthcare environment. Fourth is cultural encounters. Direct interaction with diverse patients gives us the opportunity to learn from the individual rather than relying on stereotypes. Every patient has their own experiences, beliefs, and needs, so we should allow the patient to tell us what is important to them. And finally, we have cultural desire. This is really the why behind everything else. Cultural desire means genuinely wanting to learn, improve, and provide equitable care, not simply doing it because it's required. This can include continuing our education, advocating for inclusive practices, and intentionally creating spaces where patients feel safe and respected. So, our second framework is Leninger's cultural care diversity and universality theory. Leninger gives us 3 ways to translate culturally responsive care into action. That is preservation, accommodation, and repatterning. Think of these as 3 different pathways. Preservation or maintenance means continue what helps. If a patient already has a supportive relationship, an affirming support system, or communication preferences that promote their well being, we want to preserve those. Next is accommodation or negotiation, which means adjust together. We work with patients to make care more comfortable while still meeting their healthcare needs. This could mean modifying an examination based on the patient's comfort, discussing how sensitive questions will be asked, or allowing a support person chosen by the patient. Finally, repattering or restructuring means change what harms. Sometimes the problem goes beyond an individual interaction. We may need to change healthcare practices themselves, such as revising binary intake forms, improving EHR options, replacing heteronormative language, or addressing discriminatory practices. By the end of this training, our goal is for healthcare professionals to understand sexual and gender diversity terminology, recognize disparities and social determinants of health, use these 2 frameworks, conduct inclusive assessments, recognize implicit bias, and identify changes that can be made at both the individual and system level. So now that we've had our cultural care toolkit, let's put it into practice. Our first patient is a 16-year-old experiencing anxiety and thoughts of self-harm. Let's see what these frameworks look like in an actual patient encounter.
Alex needs more than a screening tool. Now that we've discussed the importance of cultural competence, let's apply those concepts to a real patient scenario. Meet Alex, a 16-year-old adolescent who comes to the emergency department with anxiety, insomnia, school avoidance, and thoughts of self-harm. Alex's parent answers every question during the assessment and repeatedly uses a name that Alex no longer identifies with. Throughout the interaction, Alex becomes increasingly withdrawn. In the first version of this encounter, the nurse unintentionally misses several opportunities to provide culturally responsive care. The interview is completed entirely with the parent present. The nurse never asks Alex what name or pronouns they would like to use. A brief suicide screening is completed, but there are no questions about bullying, family acceptance, safety at home, or whether Alex has trusted adults for support. Instead, Alex receives a general behavioral health referral and is discharged. At first glance, this may seem like appropriate care, but when we pause and ask what was missed, we begin to see the larger picture. Research shows that LGBTQIA adolescents experience disproportionately higher rates of depression, anxiety, and suicidal ideation. These disparities are not caused by their identity itself, but by experiences such as bullying, harassment, family rejection, social isolation, fear of disclosure, and limited access to affirming mental health services. These social experiences directly influence health outcomes. One way to determine these barriers is through social determinants of health. At the individual level, Alex may be experiencing trauma, internalized stigma, developmental vulnerability, and fear of being authentic. At the provider level, the nurse missed opportunities to conduct a private assessment, explore identity related stress, perform a comprehensive suicide assessment, and provide an affirming referral. At the system level, barriers may include limited transportation, dependence on family insurance, shortages of affirming mental health providers, or living in a school or community where discrimination is common. These factors can compound one another and make it more difficult for adolescents like Alex to seek care. Now, let's rewind the scenario. This time, the nurse respectfully asks the parent to step out briefly so they can speak with Alex privately. The nurse begins asking, "What name and pronouns would you like me to use?" They explain confidentiality and its limits, perform a comprehensive suicide risk assessment, ask about bullying, family safety, and trusted adults, collaborates with Alex on a safety plan, and connects them with affirming mental health resources. These small changes can completely transform the patient's experience. This approach also reflects the Campania-Bocote model. The nurse demonstrates cultural awareness by recognizing personal assumptions about adolescent identity. They demonstrate cultural knowledge by understanding that LGBTQIA youth face higher rates of mental health disparities. They demonstrate cultural skill by performing an inclusive, culturally sensitive safety assessment. And finally, they demonstrate cultural desire, which is the genuine motivation to create an environment where Alex feels respected, safe, and heard. This encounter also aligns with Leninger's theory. The nurse preserves supportive relationships by already helping Alex, accommodates the care plan by prioritizing privacy and individualized support, and repatterns previous non affirming practices by replacing assumptions with inclusive communication and assessment. The key takeaway is that the inclusive communication is not simply about using the correct terminology. It is about creating enough trust that a patient feels safe sharing what is truly happening. For adolescents experiencing mental health concerns, that trust may be the difference between withholding information and accepting life saving support. With that in mind, we'll now transition from behavioral health to another area where assumptions can influence patient outcomes: preventative care.
In the patient, not the assumption. I want you to meet Maya. Maya is a 42-year-old woman who identifies as bisexual. Today she's coming in for her annual primary care appointment. Although she's due for preventative care, she hasn't had a cervical cancer screening in 8 years. The reason goes back to a previous healthcare visit. During that appointment, a provider told her, "Since you're dating a woman, you're probably low risk." After hearing that, Maya questioned whether routine cervical cancer screening even applied to her. She never scheduled another screening and slowly lost trust in seeking preventative care. Now Maya is seeing a new provider. Unfortunately, the appointment begins the same way. The provider asks, "So you're not sexually active with men?" Without asking any additional questions, the provider assumes pregnancy counseling isn't necessary, STI screening isn't important, cervical cancer screening can wait, and HPV education isn't needed. Instead of assessing Maya as an individual, the provider based the entire visit on assumptions about her sexual orientation. By the end of that appointment, Maya feels dismissed and decides she probably won't come back. Let's pause the story for a moment. This scenario reflects a common healthcare misconception. Sexual orientation does not tell us a patient's anatomy, sexual practices, pregnancy potential, STI risk, or which preventative screenings they need. Those decisions should be based on an individualized assessment rather than assumptions. Research demonstrates that these assumptions have real consequences. In Bowman and colleagues' 2024 study, published in JAMA Network Open, only 71% of lesbian and bisexual women were up to date on cervical cancer screening. That percentage increased to 93% among women who had an established and trusted primary care provider. However, our paper explains that finding and committing to a primary care provider isn't always easy because many lesbian and bisexual women experience discrimination or encounter providers who make heteronormative assumptions. Our paper also discusses findings from Aguilar and colleagues' 2020 study, which showed that bisexual women were less likely to attend routine mammograms or follow recommended breast cancer screening compared with heterosexual women. The paper explains that these lower screening rates are linked to previous discrimination, mistrust of healthcare professionals, and false assumptions made by providers. These disparities don't occur for just one reason. They happen on multiple levels. At the individual level, previous healthcare trauma, mistrust, misconceptions about personal risk, and avoiding preventative care can all influence healthcare outcomes. At the provider level, heteronormative assumptions, incomplete sexual histories, failure to recommend appropriate screenings, and inadequate patient education create additional barriers. Finally, at the system level, limited access to affirming primary care, insurance and financial barriers, non-inclusive healthcare education, and poor collection of sexual orientation data continue to contribute to these disparities. Now let's rewind and see how this encounter could have gone differently. Instead of making assumptions, the provider begins by saying, I ask every patient these questions so I can make recommendations based on your health, anatomy, and experiences rather than assumptions. The provider then asks inclusive, open-ended questions such as, what words do you prefer when discussing your body? What types of sexual contact are relevant to your health? What reproductive organs do you currently have that may require screening? Have you had any previous healthcare experiences that would make today's visit more comfortable? And finally, do you have any questions about HPV, STI prevention, or cancer screening? Instead of relying on stereotypes, the provider is now gathering the information needed to make evidence-based recommendations that fit Maya's individual health needs. As nurses, there are several ways we can help create a more inclusive healthcare environment. We can use gender-neutral terms like partner instead of making assumptions, acknowledge previous negative healthcare outcomes, explain why preventative screenings are recommended, avoid judgment, and use trauma-informed communication throughout the entire visit. Advanced practice nurses can also improve healthcare outcomes by recommending cervical cancer screening, breast cancer screening, STI screening, and HPV education based on the patient's anatomy, age, health history, and individual risk factors, not their sexual orientation. This approach reflects both transcultural nursing theories discussed in our papers. Todmia model encourages nurses to recognize their own biases, develop cultural knowledge, and ask inclusive sexual health questions. Leinender's theory builds on this by encouraging nurses to adapt care to each patient's individual lifestyle and experiences. Something as simple as asking about a patient's partner instead of assuming gender allows the conversation to focus on the patient's actual health needs rather than stereotypes. The biggest takeaway from Maya's story is that patients should never miss preventative care based on provider assumptions. When nurses replace assumptions with respectful, individualized communication, patients are more likely to trust their providers, participate in preventative screenings, return for follow-up care, and ultimately experience better health outcomes. That's exactly what culturally competent nursing care is designed to achieve.
Next, we're going to focus on healthcare barriers that transgender and non-binary patients may experience, sometimes before they even make it into the examination room. In this scenario, Jordan is a 29-year-old binary patient who comes to the emergency department with severe abdominal pain. At registration, Jordan's former name is still listed in the electronic health record. The intake form only provides male or female options, and staff repeatedly use the wrong name and pronouns. Once Jordan is brought back, the healthcare team begins focusing more on their gender identity than on the actual reason they came in. Unfortunately, experiences like this can contribute to patients delaying or completely avoiding healthcare. Research discussed in our paper found that approximately 23% of transgender and gender-diverse adults avoided healthcare because they feared stigma or mistreatment. Around 33% also reported experiences such as verbal abuse, sexual harassment, or being refused treatment. These barriers can happen at several different levels. On an individual level, previous mistreatment may cause anxiety, mistrust, or fear before a patient even enters the hospital. At the provider level, barriers can include misgendering, dead naming, intrusive questioning, or automatically connecting every symptom to gender-affirming treatment. At the system level, patients may encounter binary intake forms, limited electronic health record options, insurance barriers, or a lack of providers who are knowledgeable about transgender and non-binary healthcare. In the improved version of this encounter, the nurse begins simply asking, "What name and pronouns would you like us to use?" The nurse should update the information wherever possible, communicate it respectfully to the care team, and protect the patient's privacy. The healthcare team should then focus on Jordan's abdominal pain by completing a full system-based assessment as well as symptom-based assessment. Questions about hormones, medications, or previous procedures should only be asked when they are clinically relevant, not because the provider is curious or making assumptions. This scenario also gives us the opportunity to examine implicit bias. For example, a provider may assume that Jordan's pain must be connected to gender-affirming treatment. Instead, the provider should pause, recognize that assumption, replace it with a neutral question, and complete the assessment before reaching a final conclusion. A better question would be, are you taking any medications or hormones that may be relevant to your current symptoms? This connects directly to the Todmia model. Cultural awareness means recognizing our assumptions. Cultural knowledge means understanding the barriers these patients experience. Cultural skill means completing a respectful and clinically appropriate assessment. Cultural encounters mean listening to the patient's individual experience. And cultural desire means genuinely wanting to improve the care we provide. Leninger's theory also reminds us to accommodate the patient's individual communication and care needs while repatterning harmful systems such as binary forms or electronic records that do not accurately reflect the patient. Ultimately, respecting a patient's identity and providing safe clinical care are not separate responsibilities. Both are necessary for patient-centered nursing care. However, lasting improvement requires more than one respectful provider. It requires changes throughout the entire healthcare organization.
From one good encounter to a culture of affirming care. As we conclude, the focus shifts from individual interactions to creating a hospital culture where affirming care is the standard for every patient. The process begins with assessment. Hospital leaders review staff knowledge, organizational policies, patient complaints, and electronic health record documentation to identify areas for improvement. A nurse educator leads the project alongside an LGBTQIA+ community advisor to ensure the training reflects both evidence and patient experiences. The training is first piloted on one unit, where staff complete role-playing exercises and knowledge assessments before expanding organization-wide. Over the following months, all nurses, providers, registration staff, and support personnel receive the training, which also becomes part of new employee orientation and annual education. Success is measured through improvements in knowledge, confidence, communication skills, and patient outcomes. Long-term goals include more consistent documentation of chosen names and pronouns, fewer discrimination complaints, increased referrals to affirming services, better preventative care, and, most importantly, stronger patient trust. These outcomes reflect both the Campina-Bacote model and Leninger's theory, which emphasize culturally responsive care that promotes earlier healthcare engagement, better communication, and improved health outcomes. Creating lasting change also requires advocacy at every level. Individual healthcare professionals commit to respectful, inclusive care, while units and organizations improve education, policies, and electronic health records. Healthcare systems can then partner with community organizations to promote equitable access beyond the hospital walls. As we return to our patients, we see the impact of these changes. Each person receives care that is respectful, affirming, and centered on their individual needs. Ultimately, cultural humility is not about knowing everything about every patient. It is about recognizing our assumptions, listening with respect, and creating healthcare environments where every patient feels seen, valued, and safe. Thank you.